Well, welcome to our viewers and listeners to another in our podcast of interview with the experts. I'm Malcolm Bell, your studio host today. And my special guest today is my colleague, Dr. Omar Ezzeddine. He's an associate professor of medicine. He's a consultant in the division of cardiovascular, the division of circulatory failure. And he has a special interest in infiltrative cardiomyopathies. And in particular, we're going to be talking about cardiac amyloidosis today. So really looking forward to having you on the show today, Omar. Thank you for joining us.
Thank you, Dr. Bell. A pleasure being with you.
So cardiac amyloidosis, that disease that mimics so many other diseases in terms of, symptoms and signs and so often overlooked. Very important for us to be discussing that today. But in particular, our title of our discussion here is cardiac amyloidosis. And so let's just focus on the amyloid of the transthyretin protein. And maybe because that's really, I think, where a lot of the advances have been made in recent years. And so firstly, could you just tell us, how common that is and what exactly is it and how does it fit into that disease spectrum of cardiac amyloidosis?
Sure. Great question. So as cardiologists, before talking about TTR, it's very important to understand that there is another type of amyloid that impacts the heart, and that's light chain amyloid. And so the two really amyloid subtypes that cardiologists should know very well is light chain amyloid and transthyretin amyloid. And the reason that I highlight this is because the clinical presentations and the prognosis and the therapy markedly differs. And so whenever we see a patient that we're suspecting amyloid, the first thing we need to do is to rule out the more malignant of these two, which is the light chain amyloid.
And so this is the AL amyloid.
Exactly, the AL amyloid. And that is more of a hematologic malignancy, a disparate anemia that is treated with chemotherapy by our hematology colleagues. And the importance of early identification is because with each day that it goes unidentified, the patient prognosis gets poorer and poorer. In fact, median survival of light chain amyloids are around 12 to 18 months at most, I would say, without therapy. And so any talk on amyloid, the first thing that any cardiologist needs to do is make sure that they're not missing the light chain amyloid. And we'll talk more about that later. Now, going back to transthyretin. So transthyretin is a transporter of thyroxine and retinol. It's a protein that's ubiquitous to us all. But either because of hereditary reasons or advancing age, this protein, which is a tetramer, becomes unstable and breaks down into monomers, which then forms these fibrils that infiltrate the myocardium among other organs and cause, in the case of the heart, cause diastolic dysfunction, heart failure, and all the subsequent consequences of that. So again, transthyretin wild type, which is the non-variant subtype, and then the variant subtype or the hereditary subtype, depending on which gene it is, you may have a spectrum of manifestations from neurologic to cardiac to a combination of the two. As far as prevalence of disease, it depends on which populations we're talking about, particularly when it comes to hereditary type amyloid and what the mutation is. For instance, in the United States, 3 to 4% of our Afro-Caribbean population are carriers of the Val122 ILE mutation, which is predominantly a cardiac manifestation of amyloidosis. In contrast, wild-type transthyretin amyloid for the longest time was thought to be very rare, but as our imaging techniques have evolved over time and with increasing interest in therapeutic advances, now with all these studies, we're starting to recognize that actually the prevalence may vary anywhere from 6 to around 16% or so of patients, for example, who have heart failure with preserved EF. And when you start looking at various age groups, it can, particularly as our populations are getting older, it impacts anywhere from 15 to 25% of patients over the age of 80, for example. So it isn't as rare as we used to once think it is. And we finally have therapies that not only affect survival, but also affect cardiac hospitalizations and reduce cardiac hospitalizations and improve quality of life. And so for this reason, I think it's very important to recognize this entity of transthyretin amyloid cardiomyopathy.
Okay, so before we talk about diagnosis and treatment, so just if I'm hearing you right, so the TTP, is it the wild type that's more common than the hereditary one, but less common than what we would see with AL amyloid? Is that correct?
Actually, light chain amyloid is not as common. Now, it depends on where you, when you're comparing light chain amyloid, for instance, to wild type TTR, I would argue that light chain amyloid is more rare than wild type TTR. But again, it depends on which populations you're looking at. For instance, at a referral center like here at Mayo, which is a cardiac amyloid center of excellence, we get our prevalence numbers really are very biased that way. And so we do see a lot of light chain amyloid here as well. But in comparison, compared to wild type, I would say it's more rare.
Okay, well, that's very, very interesting. So let's then just focus on our TTR. So in terms of who should we suspect may have this, and what would be the diagnostic approach in these patients?
Sure. So typically, the red flags that one should think about when they're, considering this diagnosis. When it comes to amyloid, there's cardiac manifestations that include heart failure, atrial arrhythmias that are resistant to multiple ablation procedures, for example, Brady or tachyarrhythmias and pacemaker dependence. That's the cardiac manifestation of the disease. But in combination with that, there's typically, when it comes to TTR, a musculoskeletal involvement as well. Particularly, wild type involves the carpal tunnel. So unexplained bilateral carpal tunnel syndrome. Spinal stenosis, where this amyloid protein infiltrates the ligamentum flava of the spine. Trigger fingers. These are common musculoskeletal, if you want, presentations. Biceps tendon rupture is another one. And this is because of infiltration of this amyloid protein either into the tendon or the ligament. Neuropathies, either peripheral or autonomic, are also common, depending, again, on whether it's wild type or hereditary. Typically, neuropathies are more hereditary in nature, but we're increasingly recognizing wild type. So when we see a patient with heart failure who has unexplained musculoskeletal presentations like bilateral carpal tunnel syndrome that's not occupational, for instance, or biceps tendon rupture, these are things that should hone us in on the diagnosis. Now,
Let's just interrupt you. So, I mean, that's really fascinating, and those are symptoms that we've all seen from time to time. But putting them together, that patient with heart failure, or some of the symptoms that you've talked about. Just remind us, would we typically see such symptoms with AL amyloid, for example?
AL amyloid is more of a systemic disease that affects multiple organs, more so than TTR, including the heart, the kidneys, the nerves. So you end up with more autonomic dysfunction, more GI symptoms, constipation or diarrhea. Peripheral neuropathy is common with light chain amyloid. Gait disturbance could also occur in advanced stages, in addition to the cardiac.
So those symptoms and signs you talked about, carpal tunnel syndrome, spinal stenosis, I mean, we may perhaps then should be more suspicious of the patient who might appear perhaps a little bit more healthy than that patient who presents with AL amyloid. And
Correct. Some red flags that are more specific to AL, I would say on exam, pinch purpura, the head and neck, perioral or orbital purpura, macroglossia. Those are things that are more light chain related.
Those are the classic things that we were taught, many years
In
ago.
medical school, yeah. But I should mention, and you may take particular interest in this as an interventionist, Dr. Bell, unexplained troponin increases there. I can't tell you the number of times we have seen patients that come to our clinic that have gone through with an unexplained quote unquote NSTEMI or MINOCA, myocardial infarction, without clear coronary disease, because there is this phenomenon of myocardial necrosis that occurs because of the infiltration and the toxicity of the light chains. In the case of light chain amyloid, that the myocardium actually dies, and you do see troponin leaks that are unexplained. So that's another thing to keep.
That effect of that protein, deposition, the unfolded protein. So let's just move to, I think one of the really exciting areas, I think for so many people is, making that diagnosis. I mean, maybe, obviously you're going to be looking at their, cardiac function, echoes and things, but in that patient, it looks as though they may have an infiltrative cardiomyopathy, or maybe it's even an early presentation. The specific things that you want to do when you're going to try to make a diagnosis of cardiac amyloidosis, and particularly TTR amyloid.
So, as you mentioned, echo, MRI, these are great modalities to look at the myocardium in more detail, but they really don't, and they will give you, they will raise the flag, and this patient may have an illustrative cardiomyopathy. However, it does not really tell you which subtype of amyloid it is. And this is, I think, where really there's been the field has evolved in that now we actually have imaging techniques that after you have ruled out the light chain amyloid process, which should always be the first thing you do, that is specific for TTR amyloid with a positive predictive value with some of those nuclear studies of 100% after you have ruled out light chain amyloid. And so the first step always needs to be ruling out light chain. And the way we do that is by obtaining serum-free light chains and serum and urine monoclonal proteins. And that should be the first part of any algorithm of any patient that you're seeing who you're suspecting amyloid. After you have ruled out light chain amyloid, then you go down the algorithm and proceed with TTR specific if you want testing. And that in the current era, we have been very lucky to come across this technique, which is not a novel technique. It's basically cardiac scintigraphy using bone radiotracers. Technetium pyrophosphate is what we use here, but these are technetium-based bone radiotracers that are taken up by the myocardium that is infiltrated with TTR. Now, caution, because you could also have uptake of this bone radiotracer in a myocardium that has AL. Hence, the first step always needs to be ruling out light chain, because after you have ruled out light chain, the positive predictive value of a positive PYP scan or cardiac scintigraphy is 100%, which essentially gets rid of the need for invasive, if you want, diagnosis with biopsy.
We don't have too many imaging studies that have that sort of accuracy. That's interesting because you were talking about troponin elevation in some of these patients, and I guess we'd have to be a little careful because these were the traces that were used for hotspot, scintigraphy when we were looking at myocardial infarction, decades ago. Is that correct?
Absolutely. Actually, you should not do a PYP scan if the patient's had a myocardial infarction within 4 weeks. Within the last 4 weeks, you have to wait 4 weeks after an MI because, as you mentioned, absolutely, these were techniques that were used back in the day to identify MI burden.
So you have a positive scan, so with a positive scan, is there then a need to do a biopsy to confirm this? And on the flip side, if it's a negative scan, do you need to do a biopsy to exclude amyloid?
Excellent question. So if you have a positive biopsy and you have done a good job ruling out light chains, so you have no monoclonal proteins and normal free light chains, then a biopsy is not needed. If, however, there is an abnormality in monoclonal protein, and this is something we are increasingly starting to see as our populations get older, as we age, we do have monoclonal processes that happen. One example is monoclonal gammopathies of uncertain significance. So we are starting to see overlap. And in these cases where you have an abnormal monoclonal protein study, unfortunately, non-invasive testing is not sufficient, and you have to go for the tissue and perform an endomyocardial biopsy. On the flip side, negative studies. So there are false negatives that could occur with PYP imaging. There are some hereditary mutations that form what we call type B fibrils that don't cause as much myocardial, if you want, disruption. And those patients may have negative PYP scans. Also, the earlier the disease, the higher the likelihood of us missing it. So you must understand that this technique was derived and validated in cohorts of patients who had heart failure and clear evidence of amyloid infiltration. Very little is known about what burden of amyloid is needed to have a positive PYP scan. And so the teaching point is always the PYP scan is great, but if it's negative and your index of suspicion is high, still high, or if it's equivocal, then you must go for a biopsy. There's other amyloid types that I did not talk about because they're extremely rare that could present like TTR, but then after you biopsy the patient, it turns out it's something like what we call ApoA4 or ApoA1. These are very rare subtypes of amyloid, or AA amyloid, which is secondary amyloid to systemic inflammatory processes.
Well, we probably better not jump into that rabbit hole. This, I think, it's very, very long. So in the time left to us, then, unless there's any, I mean, obviously the imaging and the biopsy, and then the exclusion of AL amyloid, those seem to be the three critical steps in the diagnostic workup. But the other really exciting thing, of course, is the new treatments that we have. And just in the last couple of minutes, I mean, maybe you could just let us know what currently we're using, what may be in the pipeline in the future.
Sure. When we think about therapy, the first thing I want to say, there's only one FDA-approved agent to date, and hopefully more towards the end of the year. But it's a stabilizer of this tetramer called tafamidis. And it was studied in the ATTR-ACT trial, and it was found to reduce mortality and hospitalizations by around 30%, which is great. I mean, this is a number needed to treat of around 7 or 8, which is great for a cardiac drug if you want. It also slowed down the progression of, or the deterioration, if you want, of quality of life and physical capacities as measured by a 6-minute walk test. So the tafamidis really has become our go-to agent. It's the only one that's FDA approved for wild-type TTR amyloid.
Does it provide survival benefit too?
Absolutely. 30% reduction in mortality. Yep. So it's a very effective.
Sorry, I missed that earlier. I thought you were talking about
very, very effective drug and very minimal side effects. It actually was safer than placebo in the trial.
And expensive.
Now, the other category of drugs that we now also talk about, and these were drugs that are FDA approved, if you want, for neuropathy, polyneuropathy, hereditary polyneuropathy with amyloid. And those drugs are drugs that are gene silencers or RNA, if you want, RNA interfering agents that actually stop the production of TTR from the liver altogether. And these are FDA approved for patients who have polyneuropathy. They were studied in a cardiomyopathy patient population, purely cardiomyopathy. And although it was a positive trial, the Apollo B trial was a positive trial. It was a drug called patisiran. The signal of benefit was not of clinical significance. It was statistically significant. And so the FDA did not approve the drugs for this reason. That being said, there is a trial that we're very excited to hear more about at ESC. It's going to be a late-breaking trial that we have heard is markedly positive, that involves one of these RNA interfering agents called vutrisiran, and this is the Helios-B trial. And there's reportedly a survival and a hospitalization, and even the secondary endpoints were there was a significant benefit there. The data is yet to be shown in full granularity at ESC, and we're looking forward to that. There's another category of drugs as well that are under phase 2 and phase 3 trials, and these are the monoclonal antibodies against the TTR that are thought to extract TTR from myocardium. And again, these are phase 2 and 3 studies that will not be reported in entirety until 2025. So we're excited, and we're really excited to wait on those. And lastly, just a plug-in for the CRISPR technology, even that is a gene editing technology. There's a trial that's ongoing and expected to be done in 2028 that involves this technology where you're completely editing the TTR gene. So very exciting times for therapy. But to summarize, the only FDA-approved for TTR amyloid drug is tafamidis at this point in time, with acoramidis, which is a sister drug, which we're expecting to be FDA approved later this year, hopefully by the FDA.
And unfortunately, I guess there are still some patients who are still going to need more advanced therapy. I mean, they're obviously going to have treatment for their heart failure as well. But my last question then, just with a quick response here. Obviously, in AL, we're talking about chemotherapy, stem cell transplant, these types of things. But with TTR amyloid, is there ever need for cardiac transplantation? And if so, does that require liver transplantation as well? Maybe you could just briefly address that.
Excellent question, and thanks for bringing this up. Because indeed, if we're talking about hereditary TTR amyloid cardiomyopathy that affects typically younger patients, younger than the age of 70, then absolutely, as the heart failure advances, these patients could be candidates for cardiac transplantation. Historically, we have also done liver transplants for these patients because that's the origin, if you want, that's the factory of this protein. In cases where patients are young enough to develop the disease, we think after getting a new heart. Now, I will say, however, in the current era with these novel RNA silencing therapies, I do foresee a future where we would transplant the heart, for example, and initiate some of these patients on RNA silencers, so that forgoes the need, or gets rid of the need of liver transplantation. So, but obviously, this is all hypothetical. I mean, there's no clinical trial that's looked at this, but I do foresee a future where, and we are starting to do this in some patients actually who are a bit on the older side of the spectrum, who have hereditary amyloid cardiomyopathy, TTR amyloid cardiomyopathy, that get a heart transplant, that we are starting them on silencers to tackle their neuropathy as well.
Omar, it's really been a pleasure having you on the show here. It's a complex disease, what sounds like complex treatments, but seen with increasing effectiveness. So thanks so much for sharing your knowledge and expertise and experience with this disease that is, I think we're beginning to appreciate. It's not so rare, and it is treatable. So thank you so much for your time.
You're most welcome, Dr. Bell. Thanks for the invitation, and always happy to see these patients. So if anyone ever comes across them and has questions, please do reach out to us here at Mayo Clinic.
Okay. Well, again, I want to thank our viewers and listeners for joining us, and look forward to seeing you in some of our future podcasts.